Bismillahirrahmanirrahim. In part 1, we talked about the etiology, clinical features, and investigations of choanal atresia. Today, we will talk about the management of this choanal atresia. As we know that bilateral choanal atresia is an acute emergency, and its management is two-pronged. That one is emergency or primary management, and that is related with the maintenance of the airway, because in bilateral choanal atresia the baby could not breathe through the nose, as infant is obligatory nasal breather, so we have to provide some alternate airway. And before that is the suspicion of choanal atresia, diagnosis of choanal atresia, because eyes don't see which brain doesn't know. So who knows how many babies we lose everywhere just because of that we are ignorant of this disease, or our primary health care givers in our, especially in our rural areas, they are not aware of the disease. And then is the definitive treatment for this disease, which is under the heading of secondary management. So as far as primary management or emergency management is concerned, as I just mentioned, our first priority is to maintain the oral airway. We can use the standard neonatal waters airway with indwelling nasogastric tube, but if one is in such a situation that where even airways are not available, we can use a feeding nipple and make its hole larger and then fix it into the mouth of the baby, so that tongue is being pushed down, and baby when will be trying to suck this nipple, at the same time he will be inhaling the air inside through the mouth. This is what it is called McGowan's technique. So easy. Everywhere these feeding nipples are available. But again, point is that if you have the suspicion and you have diagnosed the choanal atresia in time, then later on, if intubation is required and expertise are available, then we can intubate the baby, or even we can think about the tracheostomy. So these are the different ways how to maintain the airway. So this is the nipple, and you can see a big hole there inside. That just cut it and the hole will be bigger, and it is being put inside the mouth till the expertise and help is available, or the baby is referred to some higher center even. These are the oral airways according to the size. So these can be used through oral cavity. They will push the tongue anteriorly, and through the lumen inside the air can go into the airway, so that airway at least is being maintained till we can subject the patient for intubation or tracheostomy or the definitive treatment of choanal atresia. As far as definitive management is concerned, of course, this is purely surgical in cases where skull base is normal and no cardiac contraindications, that all other congenital anomalies are ruled out, because in charge association we saw that even heart diseases can be associated with bilateral choanal atresia. So if there are no contraindications to general anesthesia, the bilateral choanal atresia, it should be repaired shortly after birth. While in case of unilateral choanal atresia, we can wait up to the age of 2 to 3 years of the baby. Now, surgical approaches, we have to approach up to the nasopharynx, so we can use through the nose, nasal cavity, so that is transnasal, Or by opening the mouth, we can separate hard palate from the soft palate, and between the two parts of the palate, we can approach to the choana directly. This is what it is called transpalatal approach. So these two are the approaches which are most commonly used. Otherwise, we can use still transseptal through the nasal septum. We can go a transantral, that maxillary antrum we open through the sublabial approach, and from there we can go to the nasopharynx or the posterior part of the nasal cavity. But as I said, transnasal and transpalatal are the two approaches which are most commonly used. Now, in membranous atresia, through transnasal approach, very simple, that with the trocar cannula or with a probe, we just have to perforate the membrane which is there occluding the choana, or we can use even electrocautery to make a hole there in the membrane, or even laser can be used. While in case of bony atresia, transnasally we can use Lichwit's trocar and cannula to puncture that bone, or we can use the burr with the help of a drill, or if KTP laser is available, we can use that laser. But the important point is that whatever the method is being used to make a hole in the bony part or in the membranous part, it should be followed by a stent insertion, so that the lumen is being maintained. Otherwise, there can be, a failure of this hole, and it may be closed later on. And even a series of dilatations of the choana may be required on follow-up. So again, the important point is that whatever the method is being used, the stent, it should be followed by stent insertion, and even series of dilatations of the choana later on should be instructed. So this is transnasal approach endoscopically, that this is the upper is the endoscope, and under vision we have introduced this trocar and cannula, and there we are rupturing this membranous or bony occlusion at the level of choana. As far as transpalatal is concerned, it is nowadays it is usually preferred by the surgeons, especially if previous transnasal opening is closed or failed, or in unilateral atresia. In this procedure, occlusion is removed together with some part of the vomer and border of the hard palate as well, so that the chances of recurrence are minimal, because vomer, we know that this posterior part is forming the nasal septum part there. So a part of vomer along with the border of the hard palate is removed along with that occluding bony part. So this is, the patient is lying supine on the table. Surgeon is here on the head side of the patient. We have opened the oral cavity with this Boyle Davis mouth gag, just like we open the mouth during tonsillectomy. And here you can see we give the incision on the palate just distal and parallel to the hard palate lower border, and from there we separate the soft palate and hard palate. And in the diagram you can see the choana which is occluded, this is bone which is occluding the this choana, this one and this one. So by the help of drill, as in this picture, removing this bony part, or if laser is available we can use the laser, or with the help of this forceps, punching forceps, we can remove this. And not only this bony part, this obstruction is removed, but a portion of hard palate and some part of the vomer is also removed from the midline, so that you can see now the opening is so much big is there, and chances of recurrence are minimal in this case. And as I just mentioned, the important is that some stents should be placed there to maintain this lumen post-operatively. So these are the rubber tubes which can be put there, one on one side, other one other side, but it may be displaced. So in that case they are using this U-shaped, and here is a hole also, so that anteriorly the air is going from here and it is being leaked through this hole into the nasopharynx, and from there it can go downwards towards the larynx, so that airway is being maintained. Then maintenance of the opening, it is followed by following the surgery by regular dilatation or regular bouginage is preferred to use of these indwelling tubes by some surgeons. So dilatations 2 months, every 2 months initially, but later on the period can be extended as the child grows. So with that, we come to the end of this important topic. If you think that this is helpful and beneficial for you, please like and share it with your friends as well. Any comments, any suggestions or any queries, they are welcome in the comment section. Thanks for watching.